Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/KSD. This activity is supported by an educational grant from UCB Biopharma SRL.
Hello, and thank you for joining us. I'm Dr. Silvia Messina from Oxford University, and I'm delighted to be joined today by Dr. Michael Levy from Harvard University. Welcome to this educational activity titled MOGAD in Adults, Why and How to Get a Timely Confirmatory Diagnosis. MOG antibody-associated disease, or MOGAD, is an inflammatory demyelinating disorder in which disability is largely driven by clinical attack, making early recognition and timely treatment essential. This attack can result in substantial physical impairment and significant psychosocial burden. However, management decisions remain challenging as therapeutic strategies continue to evolve. Although antibody testing is widely available, misdiagnosis remains common, and this is largely because MOGAD share clinical features with MS and neuromyelitis optica spectrum disorder. So once MOGAD is suspected, timing becomes crucial. A 2024 study published in JAMA Neurology specifically examined the time to treatment and the effect on patients' outcome. Dr. Levy, could you walk us through their key findings?
Yeah, in this study, what was done is a population of MOG antibody disease patients were looked at retrospectively, and the variables that were predicted to associate with relapse were analyzed. And the ones that were the most predictive of a relapsing disease was time to treating the first attack. So you could see on the left there that early, intermediate, and late. Early refers to treatment within 5 days, intermediate 5 days to 14 days, and late more than 14 days. And those three orange boxes indicate that any time later than treating within the 5 days indicated a higher risk of relapse. And on the Kaplan-Meier curve to the right, you could see there in the blue, the top line, being treated late, it's the highest predictor for relapsing disease. Dr. Messina, could you walk us through how this translates to patient burden and quality of life?
Of course. So a recent cross-sectional study by Saeed and colleagues examined the quality of life in people with MOGAD. They found that high prevalence of impaired quality of life in patients with MOGAD compared with the reference population. The most affected domains were anxiety, perceived stigma, cognitive dysfunction, and social interaction. These highlight the impact of MOGAD extending well beyond the physical disability. An exploratory analysis showed that patients with a relapsing disease experience significantly worse quality of life outcomes, so reinforcing this idea that recurrent attacks not only drive neurological impairment, but they also contribute to the psychosocial burden of the disease. So taken together, all these findings reinforce the importance of getting the diagnosis right and getting it right early. So Dr. Levy, your study examined the real-world diagnostic challenge in a period just before the publication of the new criteria. Could you highlight your key finding and explain why they mean for clinicians in practice today?
Yeah, it turns out making the diagnosis of MOG antibody disease is not always straightforward. When we look back at this population of 268 patients, almost 2/3 of them were misdiagnosed. The alternative diagnoses at onset were mostly optic neuritis and MS, transverse myelitis as well. And it wasn't until between 1 and 6 months later that most of our patients became accurately diagnosed, some of them because of relapsing disease, some of them because of MOG antibody testing. But because of the cumulative disability and the delay in diagnosis, almost 60% were not able to be working full-time, and 30% weren't able to work at all and had significant activity impairment. And now, please answer this challenge question.
So having established the importance of timely and accurate diagnosis in MOGAD, we will now move to the practical step that clinicians can take in everyday practice. So these include recognizing the clinical features, understanding appropriate indication for MOG antibody testing, and then differentiating MOGAD from multiple sclerosis and related disorder. Dr. Levy, could you walk us through the core clinical demyelinating events that are most indicative of MOGAD?
Sure. The most common clinical presentations of MOG are listed on the right, beginning with optic neuritis, which in adults is by far the most common presentation. In this combined cohort of patients from Europe and Asia, you can see that almost over 55% of patients presented with optic neuritis in the adult group. Transverse myelitis was a close second, and then all of the brain lesions and simultaneous diseases are much rarer. In contrast, children with MOG antibody disease most commonly present with ADEM or other brain lesions, almost half of the time. And then second is optic neuritis or concurrent optic neuritis, with many fewer cases of transverse myelitis. Keeping these events in mind, once we have a high suspicion of MOGAD, or at least suspect that it's not MS, it's time to ask for an IgG test for MOG. So, Dr. Messina, how can we interpret these results, and when is retesting for the MOG IgG recommended?
So according to the 2023 diagnostic criteria, the gold standard for testing MOG antibody is the live cell-based assay. But in case of non-availability of the live CBA, we can also use the fixed CBA, and this is a reasonable alternative. So we can use different readout to interpret results. So for the live CBA, we use flow cytometry or microscopy, while for the fixed CBA, we use microscopy. So this is the cutoff that we usually use to distinguish the clear positive from the low positive. In the micro episode portion of this activity, we will go through different clinical scenario with low positive results, and we will see how to apply then the additional MRI and clinical supportive criteria. So when are we going to repeat the MOG antibody testing? So if the initial MOG antibody test was negative but obtained after the administration of treatment, according to the diagnostic criteria, is better repeating the treatment, the MOG antibody testing just at least 3 months after the last treatment, or at the time of another attack. If the antibody testing was negative using a fixed CBA, we can repeat it using a live CBA. And then we can also consider the MOG antibody testing in the CSF. Dr. Levy, can you walk us through the differential diagnosis?
Yep, the most common diseases that are confused with MOG are multiple sclerosis and aquaportin 4 NMOSD. And this table here is useful to distinguish among them using clinical and MRI and CSF criteria. So at the age of onset, NMO is most commonly associated with the older age group, 40 plus, whereas MS is in the middle age, 20 to 40. And if children present with demyelinating disease, they most often have MOG antibody disease. The sex distribution is strongly skewed towards female in NMOSD, somewhat skewed in MS, and might be closer to equal in MOG antibody disease. Optic neuritis occurs in all three conditions, but in MS it tends to be retroorbital, unilateral, and short. In NMO, it tends to be long and severe, and in MOG, it's often bilateral. Longitudinally extensive lesions in the spine, characteristic of NMOSD, and also occurs in MOG antibody disease, but in MS, that's very rare. With area posthumus syndromes, attacks in the brainstem, that occurs in NMOSD somewhere between 10 and 20% of the time, whereas in MS and MOG, those tend to be rare. On the other hand, lesions in the brain causing seizures and other problems in the brain, much more common in MOG, especially in children, and fairly rare in NMOSD. In the brain, though, you do see MS lesions. They tend to have Dawson finger presentations. Those MRI presentations are rarer in NMO and MOG. CSF testing, very commonly you'll find oligoclonal bands in MS, tends to be much rarer in NMOSD and in MOG.
And now please answer this challenge question. Before we move on, please answer this challenge question. So to summarize, diagnosis MOGAD requires a careful assessment of the clinical presentation, appropriate use of the MOG antibody testing, and thoughtful interpretation of these results within the correct clinical context. We will now move to a series of brief case scenarios, each illustrating a common MOGAD phenotype with low MOG antibody titers to demonstrate how to apply them in real-world clinical practice. So thank you, Dr. Levy, for joining us, and thank you for watching. Optic neuritis is the most common presentation of MOGAD and can overlap with optic neuritis in multiple sclerosis and aquaporin-4 and MOSD. Because early presentation often looks similar, clinicians must actively analyze key clinical and MRI findings at first presentation to distinguish between this condition and avoid delayed or inappropriate management. So we are reviewing the case of these patients after a low positive MOG IgG to examine which clinical radiological feature at presentation can support a diagnosis of MOGAD. So this is the story of Peter, a 42-year-old data analyst. He was previously fit and well, no known autoimmune or other neurological condition. He reported a left self-limited viral infection about 10 days prior to the onset of symptoms. So he started noticing some left side migraine-like headache. Over a few hours, he started noticing also pain on eye movement and a reduction in the peripheral visual field. 3 days later, he realized that he had a complete loss of his vision on the left. So he went to the eye clinic, he was assessed, and they noticed optic disc swelling and a visual acuity of 6/60 on the left eye. The right eye vision was normal. And he reported also a severe pain. So the clinical picture was in keeping with a possible optic neuritis. So an MRI was requested, and the MRI showed on the coronal view the hyperintensity of the left optic nerve. And then if we to look at the coronal view and the axial view of T1 with contrast, we can notice a perineuronal enhancement. So the patient was then treated with high-dose steroids. The MOG antibody testing was requested, and he was also started on oral prednisolone. The pain resolved within a few days, and the visual acuity returned to normal by day 5. The antibody test came back as low positive. 1 month later, Peter came back with new mild right-sided visual symptoms while he was on prednisolone 30 mg once a day. The visual acuity was 6/7.5 on the right eye. So we repeated high-dose steroids. So if we consider like the clinical phenotype, the antibody testing, and the disease course, what are the clinical and MRI features that can support actually a diagnosis of MOGAD? One is the perineural optic sheet enhancement that is part of the diagnostic criteria, and it's very typical of MOG antibody-associated optic neuritis. And then the optic disc edema. As a supportive testing, we also had like a CSF, which was deemed as unremarkable, and the oligoclonal band were negative. And this is a summary of investigation that can help us in the differential diagnosis. Oligoclonal bands are usually positive in up to 15% of patients with an MOSD aquaporin-4 and up to 20% of patients with MOGAD, but they are very common, up to 95% of patients in multiple sclerosis. If we look at the visual evocate potential, usually the abnormality of the VEP correlate with location and severity in an MOSD aquaporin-4. In MOG antibodies disease, also, they can correlate with the location of the attack, but they normalize with the recovery. In multiple sclerosis, the abnormalities may accumulate over time, and the VEP can actually detect subclinical lesions. If we look at the OCT, we can see a marked thinning of the RNFL in the affected eye in an MOSD aquaporin-4, and these actually correlate with the severity of the optic neuritis. In MOG antibodies disease, we can have a thinning of the RNFL in the affected eye, but the abnormal results usually do not correlate with the visual acuity. So patients with a very good visual acuity can still have abnormal RNFL. The RNFL thinning is common also in MS. It's more diffuse and, as said before, can reflect also subclinical activity. About comorbidities, autoimmune disease like lupus and Sjogren are commonly associated with an MOSD aquaporin-4, while in MOGAD there is not this strong association, and not strong association also in multiple sclerosis, although they can coexist. And now please answer this challenge question. So as we have seen in this case, key clue to MOGAD in optic neuritis include optic disc edema, strong steroid responsiveness, early relapse during tapering, anterior optic nerve involvement on MRI, and the perineural optic sheath enhancement. Thank you for watching.
Transverse myelitis is a common presentation in MOG antibody disease, but it also overlaps with multiple sclerosis, NMOSD, post-infectious myelitis, and other spinal cord disorders. At first presentation, the clinical picture is often nonspecific, and early management decisions must be made to prevent further damage to the patient. In this case, we're revisiting a patient initially suspected of having MOG antibody disease, who since returned with a low positive MOG IgG result. So let's go back to the original presentation to examine what raised suspicion in the first place, which clinical and radiological features continue to support a diagnosis of MOG antibody disease, and when repeat testing or reassessment may be appropriate. So this was a 22-year-old woman with numbness in both legs. Her presentation was 4 days after onset of symmetric ascending numbness from toes to her waist. She had a clear sensory level at the waist, presenting with paresthesias and reduced bladder sensation. She also had low back pain and a Lhermitte-like pulling sensation when she bent her chin down to her chest. But there was no weakness, no gait difficulty, no visual symptoms, or any other cranial nerve findings. Medical history was notable for a recent viral prodrome. It was a self-limited upper respiratory infection. It lasted about 2 weeks. There were no recent vaccinations, no other episodes of neurological symptoms or anything like that. No medication, smoking, drug use, just rare alcohol. Socially, she was an active athlete with prior sports and hip-related fractures, things like that, but no other visual, facial, upper extremity, gait, or balance problems. On her neurological exam, the most notable finding was a sensory change. She had reduced sensation to light touch in her feet, all the way up to her thighs. There was also a clear sensory level at the waist, but pinprick, vibration, and temperature were preserved. So you can see the motor findings were fine. The strength was 5 out of 5. Reflexes were intact. Gait and coordination were all fine. There was no problem with ataxia. Here's the MRI. It shows a T2 longitudinally extensive lesion throughout most of the thoracic spine from around T4 to T9, and a smaller area of enhancement between T7 and T8, as you can see here. So after this MRI came back, we sent off for serum MOG antibodies, and we tested twice. One was 1 to 10, and one was 1 to 40. Given the entire clinical picture, though, of longitudinally extensive transverse myelitis, with a low positive antibody, we were still able to make the diagnosis of MOG antibody disease. Just to review the findings between MOG antibody disease, multiple sclerosis, and NMOSD, acute myelitis presents in all three conditions, but in MOG and in NMO, the lesions tend to be long and severe on MRI, and depending on where the lesion is in the spinal cord, it may present with different sensory or motor findings. MOG tends to present after recent viral infection. And of course, NMO is more likely to present with Erie-Postrema syndrome and with overlapping systemic autoimmune disease, neither of which were present in this case. And now please answer this challenge question. Transverse myelitis and MOG antibody disease is typically sensory predominant, subacute in onset, and often follows a recent infection, with preserved motor function and inflammatory spinal cord lesions on MRI. Recognizing this pattern supports suspicion for MOG antibody disease and helps interpret low or inconclusive MOG antibody levels in this context, and that distinguishes it from multiple sclerosis and alpha-4 NMOSD. And thank you for watching. Brainstem and cerebellar involvement occur in approximately 1/3 of patients with MOG antibody disease, usually presents alongside other demyelinating manifestations rather than in isolation, and that's in contrast to multiple sclerosis. Early presentations may overlap with some non-inflammatory conditions, which increases the risk of initial misdiagnosis. So with that in mind, let me introduce Lucas, 25-year-old man I saw a few weeks ago who's returned with a low positive MOG antibody result. Before interpreting the test, let's go back and examine what raised suspicion in the first place and how the differential diagnosis should be approached. So this is the case of a 25-year-old male with a past history of stroke. And his symptoms this time were dizziness and vertigo, presenting with binocular diplopia, headache, and gait instability, which he described as feeling like he was being pulled to the ground, and also associated with intermittent nausea. His vital signs were stable, but his medical history, he was obese, he was on chronic anticoagulation and antiplatelet therapy. So you can see there, apixaban, 5 milligrams twice daily, and aspirin daily. And these were started because 1 year prior, he had sudden onset of left on-sided paresthesias in his face, arm, trunk, and leg. These were associated with stiffness in his trunk, and the MRI at the time showed a very small medial right pontine lesion, which I'll show you by MRI, as well as a small ovoid periventricular lesion in the right parietal lobe. At the time, this was interpreted as an ischemic pontine infarct attributed to a patent foramen ovale. Mental status, he was alert and oriented. In his cranial nerves, he had direction-changing nystagmus, as well as binocular horizontal diplopia and mild dysarthria, all localizing to the brain stem. In cerebellar exam, he had left greater than right limb dysmetria and an ataxic wide-based gait, and he had a positive Romberg. On motor and reflex exam, he was full strength throughout. He had asymmetric reflexes, right greater than left, as well as patellar and ankle clonus, and a positive pectoral reflex. So our impression at the time is that this localized to a multifocal brainstem cerebellar involvement. The pattern was not consistent with a single vascular territory and was actually more concerning for some sort of inflammatory demyelinating disease. In this MRI, you can see here a big fluffy lesion in the left cerebellar hemisphere, as well as a T2 lesion in the brainstem. And you can also see a foci of demyelinating disease that was enhancing in the left parietal lobe. His prior MRI, the one that was called stroke, just showed that very small diffusion bright lesion right at that arrow tip. So his first presentation, again, just confirmed by that small pontine lesion, was thought to be an acute stroke, but now he's presenting with a subacute progression over days of a disease presentation that localizes more to the brainstem and cerebellum. On MRI now, he has multifocal CNS involvement, and this all happened while he was on anticoagulation. The pattern no longer fits a recurrent stroke disease and was more consistent with an inflammatory demyelination. And in that context, we went ahead and ordered the MOG IgG. That turned positive. It was a low positive. When we considered the differential of multiple sclerosis and NMOSD, with multiple sclerosis, you don't typically see these kind of brainstem attacks, especially that large fluffy lesion in the cerebellum. In NMOSD, you can see large lesions, but they don't tend to involve the cerebellum as much as they would, say, the brainstem or the spinal cord. In this case, the lesion was consistent with MOG. It did involve the brainstem. It had a subacute inflammatory course with multifocal MRI lesions, including that asymptomatic enhancing lesion in the left parietal lobe. And now please answer this challenge question. Brainstem involvement in MOG antibody disease typically occurs as part of a broader inflammatory attack with subacute onset and multi-system MRI involvement, unlike multiple sclerosis where brainstem syndromes are often isolated. Recognizing this pattern helps guide appropriate testing and supports interpretation of low positive MOG antibody results. And thank you for watching.
Acute disseminated encephalomyelitis is an inflammatory demyelinating syndrome presenting with encephalopathy and widespread CNS involvement. It occurs more often in children than adults, but when it presents in adults, should be carefully distinguished from infectious or other autoimmune encephalitis. So let's now consider an adult patient with encephalopathy and suspected MOGAD who was found to have low positive MOGAD IgG result. So this is the story of Lucy, 27-year-old PhD student. She has a past medical history of 2 abscesses, both operated without any problems. Then on 15th of March, she went to her GP because of persistent unilateral headache on the right side behind her ear. This lasted approximately 4 weeks. She described the pain as a superficial pain, like skin sensitivity and itchiness. She didn't have any neurological assessment at that time, and she was discharged with symptomatic treatment. Then 2 weeks later, she went to the emergency department, and she was coming back from a weekend abroad. She fractured her toe because of a fall. She was still complaining of this worsening and persistent headache on the right side. This lasted about 8 weeks. Again, she was discharged, and she didn't have any neurological assessment at that time. Then the day after, she presented again to the emergency department, and at this point, she was complaining of acute urinary retention, episode of loss of consciousness at home, so there was possibly a seizure, and she was very confused. There was loss of consciousness at the hospital when she arrived, and persistent headache and neck pain. So initially, she was catheterized because of the urinary retention. The blood test showed mild leukocytosis that then later resolved. The CT head was deemed as unremarkable, and then the lumbar puncture was also reported as unremarkable. So at this point, the working diagnosis of the emergency team was a possible viral meningoencephalitis. During the admission, there was a rapid neurological deterioration. So on day 2 from admission, she started having severe back pain, lower limb weakness and numbness. She was not able to stand without support. There was significant constipation. So all the symptoms were associated with a possible viral illness. There was a progression of the neurological symptoms. She started complaining of photophobia and phonophobia, and at this point, she was transferred to a tertiary center. She had an MRI scan, and the spinal cord MRI showed the presence of abnormal signal change that we can see here in the sagittal view, going from the cervical cord down to the thoracic cord, including also the conus. And the brain MRI showed the presence of ill-defined signal change in the pons and also in the parietal lobe, and with some involvement also of the deep gray matter. So the patient was treated with high-dose IV steroids for 5 days, and then we started on oral prednisolone. She had a marked improvement, and this is reflected by the resolution of the brain lesion and the spinal cord lesion, as we can see in the MRI scan. We requested the MOG antibody, and this came back as low positive. So the findings that are supporting the diagnosis are multiple ill-defined T2 hyperintense lesion in the supratentorial and infratentorial wet matter, but also the deep gray matter involvement and ill-defined T2 hyperintensity involving the pons, as we saw in the first scan. So if we look at the differential diagnosis, what is actually pointing towards a MOGAD diagnosis rather than a viral encephalitis? So first of all, the onset, because it was like a subacute over weeks in MOGAD, while it's usually acute and rapidly evolving in viral encephalitis. Then the presence of a brain and spinal cord involvement, which is more typical of MOGAD, the presence of an LETM with conus involvement, that it's very typical of MOGAD, the dramatic response to corticosteroid, the clinical improvement, and of course the MRI resolution. And now please answer this challenge question. So ADEM associated with MOGAD can occur in adults and is typically steroid responsive. It often presents with characteristic ill-defined lesion on MRI. It can involve both the white matter and the deep gray matter. So recognizing this radiological and clinical pattern is actually essential to help guide appropriate testing and provide context when interpreting the antibody results. Thank you for watching.
This has been an activity published by PeerVoice.